Good morning, everyone. Good morning, Dr. Stein. Good morning, everyone. So the topic that I have chosen for today is tuberous sclerosis and other neurocutaneous disorders. And there are multiple reasons that I found this topic pretty interesting. And I'd like to share those with you first. But before we start, I have something that I had written to intrigue everyone in the audience today. This is a little riddle that comes across like this, and I would want people to go about it, and let's see if everyone can find the 7 secrets hidden in there. It goes something like this. Nature found at places in a state they shouldn't be robbed. The skin of the shark, burnt the leaves of the forest, the potatoes too hard and beneath your nails, a proliferation of fibroblasts. The gatekeeper that kept me from going berserk is dead on 9 or 16. If you have me, I sure shall come out. How I might, keep guessing. So the answer to this riddle is the presentation that we have today. But obviously, I'm assuming we have a bunch of intelligent people with us here. But there are 7 secret hints hidden over here. So they all connect to the answer in some way. Moving on. Why did I choose this topic of tuberous sclerosis and neurocutaneous disorders? First of all, I've had the pleasure to see so many amazing cases of epilepsy and seizures in the past few days. And tuberous sclerosis is one neurological cause that we didn't come across as such, but it's definitely amongst there with a unique treatment that I would like to discuss coming forward. Secondly, one thing that isn't as widely known, this is the end of May, and May is celebrated as the month of tuberous sclerosis awareness. So I could not find a better time to present this. Thirdly, tuberous sclerosis is not just one disease as such, it's called a complex. So there are various phenotypic presentations, and the clinical presentations features are a visual treasure to watch, as you will all see coming ahead. Importantly, also, not just the clinical findings, but the genetic phenomenon that I can discuss through tuberous sclerosis are an amazing opportunity to learn that you'll see ahead. Also, I made sure that we didn't have to repeat any topics already in the section of presentations, hence I chose this. One important thing that I want to focus everyone's attention on is that I have certain educational pearls throughout this presentation, which I have named them as tubers of thought for very obvious purposes. Those are things that we usually do not give attention to, but they are beautiful logical reasonings that we find along the way. So moving ahead, neurocutaneous disorders, an introduction. So neurocutaneous disorders, also known as phacomatoses, I'm sure a lot of people might have heard the names like neurofibromatosis type 1, type 2, tuberous sclerosis complex, ataxia, telangiectasia, Sturge-Weber syndrome, and von Hippel-Lindau syndrome. These are the common ones, but I would like to initially bring forward to the attention for everyone what basically comprises, what's common between all the neurocutaneous disorders. Firstly, they're genetic disorders that affect multiple organ systems. Second important thing is that they're mostly comprised of benign tumors. So this is in contrast with syndromes like MEN1 and MEN2. And thirdly, they're autosomal dominant for most of the purposes. One important point that I want to focus everyone here on is that they're genetic disorders, not necessarily familial. Although most of them are familial, but a specific disorder, which is the Sturge-Weber syndrome, is mostly sporadic. So there is an associated genetic mutation, but we have to understand that there's a difference between genetic etiology and something being familial when it is passed down through the generations. Also, there are other unique, fascinating diseases, but not as common, which I have also listed here. But I would not like to now like to move forward because for anyone who's interested enough can definitely go through for the sake of completeness. But you can also see there's something very specific about neurocutaneous syndromes. The syndromic association, the defects that you'll find will primarily be in 3 directions. You'll probably find cutaneous findings, you'll also find intraocular findings, and you can also find intracranial findings. One question that comes into a lot of heads is why these 3 specific organ systems under neurocutaneous disorders? And there's a very beautiful logical answer to that. Okay, so that's leading to our tuber of thought number 1. I'm sure that we are all aware about the embryology and how the gastrulation happens. There are 3 germ layers. Not going into the detail, but one of the germ layers, which is the ectoderm, is what eventually gives rise to the epidermis of the body, as well as the neurons of the brain in terms of the neuroectoderm. So when something goes wrong in this specific lineage of cells, it is but natural that all organ systems arising from there will have some defect. Hence the logic behind neurocutaneous disorders. Also, we see the pigment cells arrive from the same germ layer. So a lot of these disorders are either associated with hyperpigmented or hypopigmented lesions on the body, as we'll discuss later. Okay, this is one special slide that I wanted to put in because we obviously focus on tuberous sclerosis more. But one academic objective I had over there was how do we need to be very cautious about when we read certain findings in certain diseases. This a specific thing which is called a tram track sign, which is seen in neurofibromatosis too. But when we read and study, what usually happens, we associate tram track and the disease that we are having, and whenever we just see that word, we think it's NF2. But it's very important that we understand what is happening and then connect the dots. So in something called NF2, we have an optic nerve meningioma. I hope that you can see the purpley shaded tram track appearance of the optic nerve over here. That is because the tumor of the meninges in the optic nerve looks like parallel roads, which is the tram track sign. However, there's another disorder as discussed before, which is called the Sturge-Weber syndrome, in which also we have something which is relevant to tram tracks, but it is not the tram track sign. It is something called tram track calcifications, which happens basically the gyri become atrophied, and then over time they get calcified and they look opposing as if they are the appearance of a tram track. So it's very important that we understand what's going on before just thinking that connecting the 2 words together. Also, another important differentiation between neurofibromatosis and neurofibromatosis 1 and 2 is that optic nerve gliomas are much more common in NF1, whereas optic nerve meningiomas, as discussed, are common in NF2. I hope that you can make the distinction. In NF1, there's a rounded mass in the optic nerve, whereas it's parallel lines in NF2. Okay, moving on to the topic of concern, which is tuberous sclerosis. First of all, before we start with this disease, which is also known as Boneville-Pringle disease sometimes, I would want to convey this to everyone. How does everything that we know about a disease come about? When it was initially described, it was a dermatologist who saw the dermatological findings, and over time, a neurologist found that there's an association with epilepsy as well. And when it was named, tubers basically mean fleshy roots, like a potato, right? And sclerosis means hardening. So when it came about, it just meant hard roots. But then the word stuck so much. And now what we are going to study across is the contribution of so many people over so many years that we'll go about in a very systematic manner. So initially, there was a triad that was told, which was known as the walk triad. So epiloia was the abbreviation for it. Epi for epilepsy, LO for low IQ, and A for adenoma sebaceum, which are the swellings that you can see over here over the face. The inheritance of this disease is autosomal dominant. One important thing is that the same disease can happen through 2 different genes genetic mutations. One over TSC1 over the 9th chromosome and TSC2 over the 16th chromosome. They both code for separate proteins, which are respectively called hamartin and tuberin. And importantly, these are tumor suppressive genes. So what comes into play over here is Knudson's 2-hit hypothesis. When you are born with a mutation in all the cells of your genes, one of the tumor suppressor genes is lost in all your cells, and it is just awaiting another random mutation in any organ. So when both the tumor suppressor genes are knocked out, you suffer from the clinical manifestations of the disease. Also, not going in the details of the disease as much, but what is extremely important to know that these genes and their protein products are involved in the mTOR receptor pathway, which is involved in a lot of angiogenesis and growth factor pathways. So logically what happens if our tumor suppressor genes are not working, and this knowledge that we have, we can prevent the manifestations or treat this disease by going down in the pathway and blocking the mTOR receptors through treatments like sirolimus and everolimus. So this is a beautiful example of how knowing a pathway helps us treat the disease. Okay, moving on. One very important educational objective I want everyone to have is, even if you forget everything about tuberous sclerosis, one word that should hit your head is something called a hamartoma. In easy, simple words, hamartomas, oma obviously means a mass, but hamartomas can be imagined as a misorganized mass, which is native to the site of the tissue. It is different from another mass that might be at an ectopic place, which is called a choristoma. But this is what is happening across the body in tuberous sclerosis. Different organs get different kinds of hamartomas, and which we perceive as different clinical manifestations. But at the heart of it, this is what is happening. So it's a tumor-like condition, but it's not a malignancy as such. All right. There are other conditions which also have hamartomas, like Creutzfeldt-Jakob syndrome. But these are self-limiting tumors. And I will let you know ahead how does that work. You can see in the images over here how a hamartoma probably looks. This is a hamartoma in a lung as well, which is one of the commonest lesions in the lung. So basically, take home message, a hamartoma can happen anywhere in the body because it's basically a disorganized mass in a tissue of its own origin. Moving ahead, epidemiology of tuberous sclerosis. So these are a few special features that I thought were worth mentioning. I'll just mention the points that I haven't repeated as of now. Firstly, the frequency, the epidemiology. It's important to understand that tuberous sclerosis happens about, on an average, 1 in 6,000 to 1 in 10,000 live births. The reported frequency changes because our diagnostic criteria have been changing over the years. But it's frequently common. It's the second most common neurocutaneous disorder after NF1. It's autosomal dominant, but don't let that happen that you think there's no family history, so tuberous sclerosis cannot happen, because mutations can still happen sporadically. All right. So one very important point with the diagnosis that happens is you always are not able to diagnose tuberous sclerosis because there is a varied list of presentations that can happen. So if a mild case presents to you, you might not even really consider or feel appropriate to visit a doctor to get the diagnosis. Secondly, the genes that I mentioned, they can have mutations, and there will be different kinds of mutations, but not every mutation will necessarily be pathological. So it's not just a genetic diagnosis as well. There can be genetic mutations of uncertain significance. So there needs to be a clinical correlation with the genetic identification of the gene. Thirdly, a very, very interesting point is, even if you think and you diagnose clinically and radiologically as with the criteria that I'll show ahead, that someone has tuberous sclerosis, and you perform a genetic test, there is a good probability that the test will be negative for the gene. And there are two beautiful reasons for the same, which I would like everyone to think about. And if not, I will in ahead tell you the reason for it. All right, moving on to the genetics. This is absolutely one of the favorite parts that I would like to discuss. There are 5 amazing phenomena that tuberous sclerosis is a beautiful example for to help me teach them with. Firstly, there is genetic heterogeneity. As I discussed, there are 2 separate genes on 2 different chromosomes, but even if either of them gets defective enough, you will get the same manifestations. You will still be considered to suffer from tuberous sclerosis. So there are 2 different genetic loci that have the possibility to individually get affected to cause the same disease. That is what genetic heterogeneity is. Secondly, incomplete penetrance. Although tuberous sclerosis is considered to have an almost complete penetrance, there are still some possibilities that it might not penetrate. To put in simple terms, we do say that it's an autosomal disease, but even if an autosomal disease does not happen in your offspring, even after you pass on the defective allele, it's known to be incompletely penetrant. So English is a beautiful language that way. If we just break down the words, we can really make sure what's happening. Thirdly, the important and a huge hallmark of tuberous sclerosis is variable expressivity. So the same defect, even in the same members of the family, can present tuberous sclerosis as variedly different diseases because the presentations can be so much diverse. So these 4 presentations are of this, can be due to the same gene but in different people. So there is angiofibromas over here, there's periangular fibroma over here, there is a hypopigmented macule, and this is something called a Chagreen patch. So all of this are not different diseases. It's a part of the same complex, but it's not necessary that the same person will have everything. The same mutation, the same tuberous sclerosis that we are saying can be expressed variably across the population. Fourth and fifth points are the answer to the question that I previously asked, how a genetic mutation can still be negative in a patient of tuberous sclerosis. We go to something called a somatic mosaic. So if the mutation, like we discussed, happens after a few divisions of the zygote or the embryo as such, not all cells of your body are going to have the mutation, right? So your body will be a mix of cells which are normal and which are not normal in respect of tuberous sclerosis. So if you get a sample from a cell which is supposedly normal, the person might still be suffering from tuberous sclerosis because the organs or the cells which are defective have the defective gene, but the test that you did was from a sample of population which was pretty much normal. This is called a somatic mosaic. So in this case, the parent still has some percentage of cells which have the disease. But in a gonadal mosaic, what happens? The parent is absolutely normal, but the defective gene allele happens to be present only in a certain population of the oocytes or the sperms. So the person will be normal, but the child that will be born will always be a case of tuberous sclerosis. So these were 2 interesting points that I wanted to put everyone's attention to. Again, one beautiful tuber of thought that I had. This is the pathway like which I discussed. The TSC1 and TSC2 are basically a complex that help inactivate the mTOR pathway. If that is lost, the mTOR is too active, and that is how you can inhibit with the corrective medications as I discussed. Now, importantly, what happens when these proteins are defective? TSC is a disease of cell size regulation. It's not necessarily a disease of cell number. So I'm sure when we used to study malignancy, the pre-malignant stage is hyperplasia, uncontrolled cell division, which leads to a neoplasia. But in this case, the cell size regulation is defective, which has 2 important consequences. What we see in TSC are not malignant lesions. That does not mean they are not consequential. Like the lesions in your brain, the segas or sub-ependymal nodules that you have will not turn malignant, but they will still have their consequences. You can have epilepsy, you can have infantile spasms. But the second point that also happens, when you initially have a suspected case, you might not see the tumors because it takes time for growth to happen. And as growth happens, it becomes unregulated. And you might find those tumors or manifestations of tuberous sclerosis later. So initially a case might not be diagnosed, but the follow-up can lead to a diagnosis of tuberous sclerosis. So moving on to the most visually beautiful part of a presentation. Let's move on to the diverse set of manifestations that tuberous sclerosis can have. This is a summary, but just to emphasize how diverse one single thing can have impacts in the body. Moving on to brain, which I'm assuming is the favorite part of most people in this room with us. We have different manifestations within the brain itself. So it's not just different organ systems that are being affected. So 4 things that pretty much happen in a case of tuberous sclerosis and in different patients expressing variably are cortical tubers, are cerebral white matter radial migration lines, are subependymal nodules, and subependymal giant astrocytomas, SEGAs for short. So we'll focus on that later, but in the lungs, something called lymphangiomatosis. Kidneys can have angiomyolipomas. In the eyes, retinal hamartomas and achromic patches, which might seem heavy words right now, but we'll have pictures for them later. And the heart, the analogous pediatric tumor of what we see as atrial myxoma, it is a cardiac rhabdomyoma. And the skin is the most apparent manifestation and the most common manifestation. These 6-7 findings are, I would not like to name them because I want to show them to you pictorially. So let's move ahead. Firstly, let's start with the most important thing that we like to think together. this is the case, a beautiful pictorial representation of different central nervous manifestations of tuberous sclerosis. I hope everyone can see a tumor inside the first lateral ventricles. It's called a SEGA, subependymal giant cell astrocytoma. And the most classic location for this tumor to be present is the foramen of Monro, which connects the lateral ventricles to the third ventricle. Understandably, the features will include a hydrocephalus, right? And secondly, you will also see some swellings on the cortex, which looks like a potato. And that is how the name came about. These are tubers, basically, cortical tubers of tuberous sclerosis. Thirdly, you will also see, if you identify very carefully, due to these masses, the tubers, there are radially stretching lines which connect the tubers to the ventricles. These are also one of the features that I discussed with you during the CNS manifestations, right? The other names that I've written, I will be writing forward. But just understandably, because of the tubers, what is the most likely thing that will happen? That is epilepsy or seizures, right? So that is how, when we initially discovered and described tuberous sclerosis, we described it as epiloia, because those were the most easiest and most prevalent manifestations that we could find when before the advent of imaging and stuff. All right. So I did talk about SEGA, but I did not talk about something called subependymal nodules. So subependymal nodules are smaller calcified areas beneath the ependyma, most likely near the ventricles, which are seen here. So the first image is a CT, because you can guess that with a white bone over here. And the second image is that of an MRI. The hyperintense white lesions in the first one and the hypointense lesions in the second one are both subependymal nodules. What can happen over time? They get calcified, and also they can get converted into subependymal giant cell astrocytomas, the first one that we talked about. The third one is again the subependymal nodule. Moving on to the most visually provoking, visually recognizable lesions. So again, the beauty of variable expressivity. You see over here angiofibromas over the malar region of the face, which are called adenoma sebaceum, which, my friends, again is a beautiful misnomer. They are neither adenomas, they are nor related to sebum, but that is how it works. I mean, initially when they discovered, they did look like acne, so probably that was the reason they had this name. But these are again just hamartomas, because at the end of the day, they're coming from the same mutation. The second one is a leathery appearance of the skin, which is called a Sjagren's patch. The third one is something called an ash leaf macule. So it looks like a leaf over here, but I would really like to give this tip that let's not recognize an ash leaf macule by its shape, rather the fact that it is hypopigmented. Because in something called neurofibromatosis 1, we have a similar macule, which is called cafe au lait spots, but the distinction is they're hyperpigmented. So to help you remember that, it's like a stain of coffee that we have, which obviously needs to be hyperpigmented. The fourth one is periungual fibromas and ungual fibromas, subungual fibromas. So these first four manifestations are considered as major manifestations of TSC. A few minor manifestations include these points that you see over the teeth. They are called dental pitting. And then this gingival hyperplasia is gingival fibroma, probably, that are also minor manifestations of TSC. So I've just mentioned a few, but I hope that makes the point that how much diversely this disease can present. Moving on to the ocular manifestations, the first one looks like a mulberry. That's what a retinal hamartoma is. And the second one, you can see there's some achromic spot over here. So these are the two possible manifestations in the eye. Moving on to the fact that it does not affect just organ systems relevant to us as much, but as much to a cardiologist and a pulmonologist. There is something called a cardiac rhabdomyoma. Important to know over here is this presents before 1 year of age, but regression also happens by 4 years of age. So echocardiography is the investigation of choice. The most common location is the septum, originates from something called spider cells. And the second part that I want to get everyone's attention to is something called lymphangioliomyomatosis, which is a lot of cystic lesions which are apparent in the lung. This is an HRCT of the lung. I want to focus everyone's attention to a point, how important it is for understand the pathogenesis of a disease. So if we are suspecting tuberous sclerosis in a child before 4 years of age, then we are going to consider an echocardiography, because then we suspect a cardiac rhabdomyoma. Whereas lymphangioliomyomatosis happens about 30, 40 years of age. So your investigation choices of investigations change as per the same diagnosis, but in different aged patients. Okay, this is again a beautiful hamartoma of the renal tissue. But what's beautiful about this tissue is that it's named so beautifully. It's called an angiomyolipoma, and it gives all the information that you need. You have blood vessels being grown, you have the muscle component being grown, and you have fat that is grown. So this mass has 3 components, and all of them are mentioned in the name. That is how they look over here. So moving on to something which is relatively recent, but again, not only just structural abnormalities associated with tuberous sclerosis, but also neuropsychiatric disorders, which again comes under our YAM. So they are called TSC-associated neuropsychiatric disorders, which are as real. And I'm glad that the attention is being focused to them in recent times. So they can range from ADHD, autism spectrum disorders, depression, from sustained imperfections in certain cognitive abilities. So yeah, you can definitely go to Tandem for knowing more about this disease. Moving on, how do we diagnose tuberous sclerosis? So there's a table about everything that we discussed, which some are considered major features, some are considered minor features. My focus is not going to be to make you cram all of these, but to make you understand how a complicated disease is logically interpreted and diagnosed through systematic tables and logic, which are constantly being evolved. So 2 major features or 1 major with 2 or more minor features lead you to a definitive diagnosis, whereas a possible diagnosis is by 1 major feature and more than 2 minor features. Again, I hope that everyone sees that there is no necessary genetic identification here for the reasons that I told you, but definitely the diagnosis is largely supported and highly recommended if we can genetically analyze through techniques like FISH and RT-PCR. So I will not go through the lesions again. Let's move ahead. And the diagnosis, like we discussed, we have certain challenges with the current system, and that is the reason that diagnostic guidelines are always being updated. So there are variants of uncertain significance. It's not that TSC1 and TSC2 mutations will always be certain specific mutations, and there is no one normal. The normalcy has to be correlated with the clinical features. There can be changes, but they do not necessarily lead to tuberous sclerosis. The same mutation can affect parents and children differently. So you cannot always use the logic that if we are having the same disease in the parent, the child is affected or not. And then the mutations can happen in forms of mosaicism or in introns and modifier genes, which do not really affect the child as such. So this is the illustration of a mosaic, like I discussed earlier. We'll move on management, and I'll go through about a little. So what happens once we diagnose? I think it's going to be pretty much easier for us to understand all of this because we've discussed all that can go wrong in tuberous sclerosis. So if there is a 3-generation family history, I think genetic testing, counseling to confirm diagnosis is the most logical thing that we can do. It's not 100% yes or no for the reasons that we discussed earlier, but it's definitely sensible to do that. MRI brain with and without contrast to look for those tumors that we discussed, those central nervous system findings. Routine electroencephalography, if abnormal, then definitely makes sense to go ahead with the 24 hours continuous EEG. TAND screening, the neuropsychiatric manifestations. MRI abdomen, because we are suspecting a possibility of renal angiomyolipomas and other hamartomas, right? Electrocardiogram, because again, can be a rhabdomyoma. In children less than 3 years, an echo, and in women greater than 18 years, CT test. For the same reason that I discussed, the age will determine what we are suspecting. Ophthalmic evaluation, absolutely important, and dental evaluation, like I said, for dental pitting and fibromas in the gingiva. So these are the management guidelines at diagnosis. You definitely need to follow them up, right? Okay, so one of the most interesting things that I had, I mean, you guys will have to see this for yourself, what hints you could come up with and what hints you could not. But I hope that these will be pretty much interesting to you. So the first line says, nature found at places in state they shouldn't be. So that reflects that we are expecting to find a lot of hamartomas, proliferation of non-cancerous cells at original locations, right? The second line says, robbed the skin of a shark, because shagreen patch resemble a shark's skin. That's the second hint. The third is burnt the leaves of the forest. So ash leaf macules. Fourth are the potatoes too hard and beneath your nails. So tubers are potatoes, right? And beneath your nails indicates subungual fibromas. The gatekeeper that kept me from going berserk, dead on 9 and 16. So the two genes that we are talking about, TSC1 and TSC2, are gatekeepers because they're tumor suppressor genes, right? And importantly, it's or over here. So either 9 can go berserk or 16 can go berserk. Both will lead to tuberous sclerosis. And lastly, if you have me, I sure shall come out. This indicates that there's a near 100% penetrance, that it will come out. But how I might keep guessing, because again, there's a variable expressivity. Even if you have tuberous sclerosis, how it will present, it's anybody's guess. So that this is the last slide that I have, but this is an association that helps spread awareness about tuberous sclerosis. Please visit this website. Julianne Moore recently endorsed it. So if there's anything else, please feel free to ask any questions. And happy Tuberous Sclerosis Awareness Months to everyone. Thank you.